In this video, I'll be discussing issues related to older folks in multiple sclerosis. What does older folks mean? And what kind of issues do they have? To learn that and much more, don't turn away, because it starts right now. Howdy! Thanks for learning about MS with me, Aaron Boster. I started this YouTube channel to help my own MS clinic patients learn between visits. And it's my hope that through these videos, I can help you learn too. Today's video, we're answering a question written in by viewer Kathy Foss. Kathy writes, Dr. B, sometime could you do a whole segment on the older MS patient, like 60s or 70s? There's a lot of us, and we often get overlooked in the clinical setting, or doctors don't want or like to treat us. Well, Kathy, this video is for you. Let's jump in. As sad as it is to admit it, Kathy is spot on. A lot of MS specialists get very excited about new young patients in whom they can start on the newest, latest, and greatest medicines, patients in whom they can enroll in clinical trials. I've actually talked to MS specialists that decide that when a patient gets to be a certain age, well, they can just send them back to their primary care doctor. And honestly, I think that's god-awful and dead wrong. All of us will be old at some point if we're lucky. Every single person with MS will eventually be an old person with MS. And the importance of managing the disease doesn't go away. It doesn't become less important. In fact, I would submit it becomes more important as we age. In this video, I want to walk through several aspects of MS care through the lens of an older person with MS. Now, when I say older, what do I mean? Let's define older for the sake of this video as people that are 60 and up. As I age, old keeps getting pushed back farther and farther. And I have many people that I take care of that are in their 60s and 70s and even early 80s, and they're killing it. But for the sake of this discussion, we will define older as 60 and up. And the first issue that I want to talk about is disease modification, or the use of disease-modifying therapies. So let's start there. I made a video last summer on this topic, whether or not we should stop disease-modifying therapy in older folks with MS. I'll throw a link up above in case you want to check that video out, but I think it's worthwhile to talk about it here for a bit as well. There's a debate raging in the United States right now amongst MS neurologists about whether or not we should stop disease-modifying therapies in stable older adults with MS. Now, as you might gather, my opinion is that's a really bad idea and that we should not stop DMTs as people age. But I want to walk through the arguments with you. Those that would support this idea would point out that A, people's immune systems quiet down as they get older. And when you look at the data, folks are less likely to have clinical attacks or new spots after the age of 60. There's even some early work that might suggest that a given DMT is less impactful at an older age than a younger age. And given that the drugs don't become cheaper, and given that the risk profile doesn't go down, these people put all these facts together and say, well, maybe we should stop. And I think that's nuts. Disease-modifying therapy plays several roles, and those roles don't stop as you get older. They just change. When you are, say, 65, you are statistically less likely to suffer an attack as compared to when you're 25, but you're also less likely to recover. So taking a DMT as an insurance policy against an event, it's a different set of variables. You're less likely to have the event, but if you do, it's more severe. So it still serves a very important purpose. Moreover, disease-modifying therapies do more than just stop spots and attacks. They slow brain volume loss, which is a really, really good idea. And you don't want to give up on slowing brain volume loss just because you hit a certain age. They have been shown to improve the quality of people's lives. And if you look in some of the early beta seron studies that have now gone on for decades, it actually seems to prolong life, quite literally. My point here is, when I look at a given individual, whether they're 20, 30, 50, 90, I think that we have to view them as a human, as an individual person with individual goals. And we need to openly and honestly discuss the risk-benefit of keeping them on any medicine, and we have to really put it in the context of what's going on. If you have a really spry 65-year-old who's tolerating their drug great and hasn't had any side effects, I struggle to understand why we should rip them off their drug. But again, I want to point out that it's important not to be ageist. And I don't want to make an en bloc statement that everyone at a certain age needs to stop their drug. I think that we will do much better as a treating community if we look at individuals as just that, individuals, and constantly reevaluate the risk-benefit of a given therapy in a given human as they get older. Now, that doesn't mean that as a group you might come to the decision that we're going to come off medicine. Okay. But I don't think that we should do that across the board. So those are my 2 cents on disease-modifying therapy. Now, many of you that watch the channel know that I'm a proponent of the de-escalation model. Again, I'll throw a card up here so you can check out a video I did on de-escalation. And I think that as opposed to stopping a medicine as someone hits the 60, 70, 80 mark, it might be reasonable to de-escalate the medicine. And so to hear more about that, check out that link. Another really important topic to consider as we discuss older people with MS is the effects of natural aging. So when I see a 60-something in the clinic and they say, I'm really tired, but honestly, all my friends at Bridge Club, yeah, they're tired too. It's a really good point. There is a natural aging process, and as we get older, our skin gets thinner, we get shorter, our brain volumes shrink, we can develop difficulties maintaining muscle mass, and with mobility, we can maintain or develop difficulties with thinking and memory. So, when someone has MS and they're getting older, how the hey do you sort out one from the other? It's not a straightforward thing to do. And I think it's all the more important that we really embrace brain health. We want people with MS to not smoke cigarettes. We want them to address cardiovascular risk factors like high blood pressure, hypertension, obesity, sedentary lifestyle, diabetes, because all of those things will harden the arteries. They'll result in accelerated aging of the brain. They'll result in accelerated brain shrinkage, separate from MS. And so by addressing those cardiovascular risk factors throughout your life, by remaining physically active, by constantly moving, by exercising as part of your lifestyle, this is all part of brain health. To finish the thought, we want to drink alcohol in moderation. We want to probably be very conscious about recreational drug use for the same reason. And we want to make sure that we're eating a clean diet. I don't want someone under my care to live off of McDonald's and Diet Mountain Dew. I don't want them to do that when they're 20, and I certainly don't want them to pay the price of that behavior when they're 60. So the point here is we can't stop aging, all right? We can't make ourselves not age, but we can impact the rate of aging by embracing brain health. And that's going to put us in the very best position to enter into the 60s, 70s, and 80s as healthy as possible despite having MS. And now for coffee. If there's someone who's older with MS, and even if they're off a disease-modifying therapy, that does not mean they shouldn't be cared for at an MS center or by an MS neurologist, because there's a tremendous amount of effort to be placed on optimizing the quality of life and on treating symptoms. And this is far too often completely overlooked, and it drives me nuts. The person with MS may be suffering from a host of largely invisible symptoms, which is destroying the quality of their life, and they're not being addressed at all. And so I really encourage doctors taking care of folks with MS and people impacted by MS to insist upon engaging in these symptomatic management and dealing with these quality of life issues. So things like pathologic fatigue, things like poor sleep quality, things like difficulties with thinking and memory, things like depression and anxiety. These are very, very common issues in MS, and they don't go away just because you're 60. And if we don't address them, it colors everything ugly. There's more, the down there's. Bowel function, bladder function, sexual function. We have to address these. And again, they are a major issue for any adult of any age. Mobility, pain, spasticity, spasms, cramps, Charlie horses, these are all things that many people with MS have. and we don't want to stop trying to address them just because someone hits a certain age. I also think that we really have to consider balance and risk of falling. These are all symptomatic issues that we really should be addressing with every human with MS at every visit. And those needs don't just stop suddenly because you have your 60th birthday. And so if you're listening to this video and you're impacted by MS, I want you to think critically, do I have any of those issues? And if you do, you need to be your own advocate. You need to march into your doctor's office and say, hey man, I've got neuropathic pain. Hey, I've got bowel issues, and get them worked on and get them addressed, because the result is that it'll make your quality of life skyrocket. And I want that for you. Now, I'd like to get into a couple specifics. I want to talk about polypharmacy. Polypharmacy is a doctor word, which means, Jesus Lord, you're on a bunch of medicines, way too many medicines. Now, the average person with MS is on 7 medicines in the United States, and that's a lot of medicines. And doctors are pretty darn good at prescribing medicines, but we're not very good about taking medicines away. So, if you've lived 60 or 70 years, that's a lot of opportunity for your doctors to keep adding on medicines. And you may result in taking upwards of 20-some pills a day. That's too many. And so I think that addressing polypharmacy with all people with MS, but in particular with folks that are a bit older, is a really good idea. Here's the deal. Medicines have side effects, and medicines that have beneficial effects for the human being, for example, a bladder pill, may have a side effect of causing difficulty with thinking and memory. And so it is appropriate at every single clinic visit to scrutinize the medication list and to ask, is there anything on this list that we can cut back on? Is there a pill that maybe we don't need to take that high of a dose for? Is there anything on the medication list that we can literally remove, that we don't really need anymore? And if we're going to add a medicine, is there a medicine that we can take away in exchange? That's a conversation that I think we should have with all people with MS, and it's even more important as we get older. I specifically want to call out some naughty actors, things like pain medications, spasticity medications, and bladder medications. These are medicines that can cloud the sensorium and make us have difficulty thinking, and that can be more of an issue as we age. Food for thought. Another really important issue is that of bone health and fall risk. People with MS over the age of 50, both men and women, have an accelerated bone loss, and so their bones get thinner faster than the general population. And this can lead to fragile, thin bones. And if you live where I do in Columbus, Ohio, in February you risk slipping on ice and shattering your hip, which is devastating. And so we have to pay attention both to the integrity of the bones, the bone health, and to fall risks, two separate related things. Taking supplemental calcium and taking vitamin D with the supervision of your doctor may be very important. Participating in activities where you're stressing the bones, for example, lifting weights or even just walking, can really be very, very helpful. But I think all of this is predicated on knowing your bone health by getting a DEXA scan, a bone density test. It's my strong opinion that all people with MS over the age of 50 need to get a bone density test every couple years. And if we identify, yes, you have osteopenia or osteoporosis, those are doctor words for thinned bones, then we need to do something about it. There are medicines that push calcium into the bones, which you can take, and there's activities, as I just mentioned, which can facilitate strengthening up the bones. At the same time, we want to think about the fall risk. And during the winter months here in Ohio, there's a major fall risk just going outside. So paying attention to your shoes, paying attention to using assist devices like a cane or 2 canes or a walker, paying attention that your driveway is shoveled, etc., are really important points. I will do an entire video on preparing for the winter and avoiding fall risks, so I'll hopefully put that out in the next couple weeks or so. But this is an issue which we want to pay very close attention to. And it's an issue which becomes much more relevant amongst folks with MS as they get a bit older. Another issue that I see all too often with folks that are a bit older that have MS is they may not embrace the rest of their health maintenance. They spend so much energy, resources, and time invested in managing their MS that they're not up to date with their dental work. They're not up to date with their annual or biannual teeth cleaning. They're not up to date with their annual dermatology screen for cancer. They maybe haven't done a mammogram, or they haven't done a colonoscopy the way they're supposed to. Now, as my mentor used to say, sometimes nature's too generous, and sometimes you can have two problems, MS and something else. And so one of the jobs that I think we have as MS neurologists is to help remind people with MS of any age that they need to keep up on their health maintenance, and you don't get a buy for the rest of life. And so that's another element that I think that we have to consider when helping someone who's a bit older with MS. Another important issue to talk about is that of social isolation. Sometimes MS can make us feel very, very lonely. Sometimes we lose friends. Sometimes we stop working. Sometimes we become almost shut-ins where we don't do much outside of our home. And social isolation is a major issue in multiple sclerosis. It worsens depression, and it can do a lot of negative things. And unfortunately, as we age, we're at increased risk of social isolation. It becomes all the more important to seek out social support systems. It's all the more important to reinforce social networks. Support groups, going out with your girlfriend to have coffee, participating in church activities, going to read to children at the library, whatever the case may be. It is important that older adults with MS stay as socially, intellectually, and physically active as they can. I also want to point out the important issues surrounding neglect and elder abuse, because I see this in my clinic. And if you are an older person with MS and you are being neglected or you are suffering from abuse, you don't need to go through that alone, and there are support services. I'll throw a 1-800 number on the screen right now, and I want you to jot it down or call it if need be. Let's spend a few moments talking about the home. We spend a lot of time there. And as we get older, there may need to be modifications to the home so that we can continue to live there and continue to be as independent as possible. Things like moving the bedroom to the first floor, or installing a chairlift that takes us up the stairs, or installing railings or a shower seat or things like that. Now, I want to share an awesome service by occupational therapy called a home safety evaluation. An occupational therapist can come to the home, this is paid for by insurance, and they'll assess the needs in the home and come up with a plan to make it better. I recently published a video on home modifications, and I'll throw a link right there if you want to see a whole hour dedicated to the topic. Good stuff. Another viewer wrote in, Andrea W., who wrote, "I'm very positive, but what's the real end of our disease?" And this touches on end-of-life issues. Every single one of us is going to die, and I'm commonly asked in clinic, what's in store with advanced MS? So let's directly address this topic. When I am screening someone in clinic for things that I'm worried about, particularly when they're a bit older, 3 things jump to the top of the list because they relate to ways that people with MS can expire. The first one is aspiration pneumonia, where you're swallowing incorrectly and some of the food is going into the windpipe instead of the esophagus, and it can cause a pneumonia. And so if you're having difficulties with speaking or swallowing, or you're coughing or sputtering or gasping when eating, you don't want to ignore that. And you want to get it checked out. And speech pathologists can do very intricate studies of swallowing and come up with ways of keeping things safe. So that's number 1. Number 2 deals with the bladder and specific urinary retention. People who have urinary retention are keeping stale urine in their bladder, and that can track back up into the kidneys and cause urosepsis and cause death. And so if you're having frequent urinary tract infections, if you have difficulty emptying your bladder, if you have a foul smell to your urine, you want to bring that to the attention of your doctor. This is a very easily treatable thing, but untreated can lead to very serious and grave outcomes. The third one is decubitus ulcers or bed sores. And as we age with advanced multiple sclerosis, for some people it's really hard to move around, and they can become immobile or part of their body can become immobile, and when they're sitting or laying down, there may be constant pressure on a part of their body, whether that be the buttocks or the back or the shoulders or the heels. And we want to inspect our skin every single day. If we're noticing that we're having redness or the beginnings of ulcers, we want to address it immediately, because decubitus ulcers can get very, very deep. These bed sores can get very deep. They can cause infection and seed the bone, and that can also cause a sepsis and death. So whenever I'm seeing someone in clinic, particularly someone who is a bit older or someone who is a bit immobile, I want to be thinking about those three things: aspiration pneumonia, difficulty with swallowing safely; bladder issues with bladder retention, frequent urinary tract infections; and lastly, decubitus ulcers. And so those are things I want to keep in mind. Also, as we talk about end-of-life issues, I think that we have to address head-on our end-of-life wishes. I made a video about this, I'll throw links there for you, where I talk about the importance of talking to family about what you would like done, God forbid, if you were in a coma and couldn't communicate. And I'm talking about things like do not resuscitate, do not intubate. And if you haven't had this conversation with your village, I hope this video serves as a call to action for you to go into the living room and say, hey honey, I just want to share with you my wishes. Or to call your son and say, hey, I want to share with you my wishes. So if you haven't checked out that video, I go into some depth, but these are really important end-of-life issues that we all have to deal with. And people with advanced MS or older folks with MS don't escape them. Question of the day: what are your thoughts about older MS? Do you have concerns that have not been addressed in this video? And if so, leave them in the comments below. I look forward to reading them, and if we need to do a follow-up video answering specific questions, I would be more than happy to do so. If you would like to learn more about multiple sclerosis and up your game, check out this playlist right there. YouTube Analytics thinks that you would adore this video right there. And if you haven't yet subscribed to my channel, please consider doing so. Just click that circle with my face in it. Go ahead, click my face. My name's Boster, and I want to thank you for learning about MS with me. And until my next live stream or my next video, take care.